recurrent branch of the ophthalmic artery. Optic foramen and canal. The optic canal is around 5 to 10 millimeter long. It is located in the lesser wing of sphenoid. It transmits following structures: the optic nerve, ophthalmic artery, sympathetic nerves, optic foramen. It is the orbital end of the optic canal. It measures 6 millimeter, and the anatomy of this lecture is important. It's very important. Photo as well. This is the superior orbital fissure and the optic foramen. So this is the superior orbital fissure. This is the optic. Here we can see the optic nerve, and this is the ophthalmic artery. This is the optic foramen, and here we have the superior orbital fissure.
لو تقدر الدكتور تستخدم علامة اللي تكررت.
This is the optic nerve. This is the ophthalmic artery. This is the optic foramen, and this is the superior orbital fissure. This one. And you can see everything here. You can just read it later. This is just other photo. We can here. This is a very good photo. This is the optic foramen. We have the optic nerve and the ophthalmic artery, and then we have the superior orbital fissure here. So the superior orbital fissure, we have everything: third, fourth, sixth, and ophthalmic division. Not all of the fifth, only ophthalmic division of the fifth. So this is the superior orbital fissure. The inferior, we have the maxillary of the fifth. There we have what? Ophthalmic division. But here we'll have the maxillary division of the fifth. We have the zygomatic. We have the inferior, so inferior orbital fissure, inferior ophthalmic. There are 4 surgical spaces in the orbit. These are of clinical importance, as the inflammatory in any of them, and each space may be opened separately. We have the subperiosteal space. It lies between the periosteum and the bone. The bone is covered by something called periosteum. There is a space between them. This is the subperiosteal space. Peripheral orbital space. It lies between the periosteum and the extraocular muscles. It is continuous circles with extraconal. This is extraconal. We'll see this later. So just know what is extraconal, something out of the cone. Then we have central space, which is a cone shaped space enclosed by the extraocular muscles. So this one and this one will you'll see it later, because these two are very important. Then Tenon's space, it's situated around the globe underneath the Tenon's capsule. So this is the cone. This is the cone. هذا الكون اللي هو المسلز. هذه المسلز الميديال rectus والlateral rectus. السبيس in between هذا هو الكون. This is the conical space. Here البلو, this is the extra, يعتبر extra conical اللي هو out of the cone. Why it is important? Because if you have anything here inside the cone, it will cause axial proptosis, which means that the globe will be pushed anteriorly. And that's it. However, if you have something in the extraconic, in the blue area, the globe will be pushed. It will be pushed to the right or to there will be asymmetrical globes. Not only pushed anterior, no, it will push toward the side as well, as we mentioned in the lacrimal gland in the previous lecture. lacrimal gland tumor for example، لأن طبعا هي lacrimal gland extraconical خارج الكون، it will be pushed الجلوب it will be pushed to the other اللي هو opposite area. هنا قلنا lacrimal gland up و outer. So if you have something up and outer area which is too large, the globe will be pushed to the opposite side, so the globe will be pushed down and inside. So this is the idea of conical, which is here, and extra conical. So if we have, this is the optic nerve, for example, some في الميدل. If we have a tumor here, for example, في الoptic nerve, we have the optic nerve مثلا glioma or optic nerve angioma here. We have large tumor in the middle. The globe will be pushed anteriorly. Proptosis here, axillary. This is very important. This is very important structure, which is the orbital septum. Why it's very important? Because anything anterior to the orbital septum, it is extra orbit, not in the orbit. Anything posterior to the orbital septum, it is orbital structure. And this is very important to differentiate between the preseptal cellulitis and the orbital cellulitis. Orbital cellulitis is inflammation inside the orbit, يعني beneath this، خلف هذا الحاجز. However, in orbital septum, في preseptal cellulitis, the inflammation is anterior to the orbital septum. يعني orbit is still not inflamed. This is the main difference between preseptal and orbital cellulitis. Again, this is the orbital septum اللي هي الاريا هذه, and we can see that the lacrimal sac is what? Lacrimal sac is not orbital structure because it's out of the septum, not inside the orbit. However, a lacrimal gland, it's in the orbit. Part of it is orbit and part of it is extra orbit. But it's very important to know that the lacrimal sac is extra orbit, لها بعد السبتم. Again, this is the lacrimal sac is extra orbital structure. Diseases of the orbit. First, we'll talk about the preseptal cellulitis. It's an infection of the subcutaneous tissues anterior to the orbit. It's more common than orbital cellulitis. طبعا لأنها أخف من orbital cellulitis, ف anything is less will be more common. Rapid progression to orbital cellulitis may occasionally occur. So it may be start as preseptal, then it will be transferred to orbital cellulitis. Main organism is Staph aureus. Staph aureus is the most common cause of preseptal cellulitis. It causes skin trauma such as lacerations or insect bites, most common cause. So the most common cause of preseptal cellulitis is trauma. Spread by focal, ocular, or periocular infections such as acute hordeolum, dacryocystitis, conjunctivitis, sinusitis, hematogenous spread from remote infection such as the upper respiratory tract or middle ear. Signs and diagnosis: the condition manifests with swollen, often firm, tender, red eyelid that may be very severe. However, in contrast to orbital cellulitis, proptosis, chemoses are absent. So, in no proptosis. Why? لأنها not in the orbit. The inflammation is anterior to the septum, and nothing is pushing the globe, nothing is pushing the eye. Visual acuity, papillary action, ocular motility are unimpaired. Unimpaired, which means what? Normal. يعني everything is normal here. الفيجوال acuity is normal, pupillary reaction is normal, ocular motility is normal. Why? لأنها extra ocular, extra orbit. It's not in the orbit. If it's in the cone, هذا الكون قلنا. It's in the cone. يعني if there is anything here, here or here, the visual acuity and pupillary action will be affected. Why? Because it will affect the optic nerve اللي هو في الميدل. هذا optic nerve. فoptic nerve will be affected يا اما directly او because of the edema يعني will be compressed. فالorbital البريسبتال cellulitis بيكون هنا الانفلاميشن not in the orbit. هذا الاوربت الانفلاميشن في البريسبتال هنا. The patient is often pyrexial imaging with MRI or CT is not indicated unless orbital cellulitis or is suspected. A treatment just give systemic antibiotics orbit oral except in severe cases يكون IV بس mainly يعني mainly تكون oral. يعني البريسبتال يعني you should give systemic not only topical. You should give systemic antibiotics in preseptal cellulitis. This is how it looks. This is preseptal. هذا عندنا الآن هذه axial CT. This is axial CT scan shows opacification anterior to orbital septum. فالinflammation واضح إنه هنا only. This is the orbit. Looks very clear. Nothing here. Nothing. Inflammation is only in this area which is the anterior to the orbital system اللي هو هذا العين. بينما الأوربت looks very clear ف it's extraorbital inflammation. الأورbital cellulitis in contrast to the preseptal, it's a serious condition. It may endanger the vision and even the life as well. Etiology, any age or any sex may be affected. It is unilateral usually. It's often due to extension of infection of the neighboring parts such as the nasal sinus, especially the ethmoid sinus. So, البريسبتال cellulitis, the most common cause is trauma. The most common organism is Staph aureus. بينما in orbital cellulitis, the most common cause is ethmoidal sinusitis. Ethmoidal sinusitis is the most common cause of orbital. Penetrating injury of the eye with or without retention of foreign body. It may occur from and panophthalmitis. Metastasis from septicemia may also cause orbitalitis. Sepsis, severe excruciating pain, particularly on movement of the eyeball, because this is because the muscles are affected or compressed as well. There is inability to open the eyes due to chemosis, swelling يعني of the lids. Diplopia may be present due to impaired movement of the eye. So signs يعني just the redness with swelling is the common they are in common between preseptal and orbital cellulitis. However, in orbital cellulitis we have many signs that are absent in preseptal cellulitis. Vision impaired, ocular motility is impaired, pupil reaction is impaired in orbital cellulitis. Pain with movement is mostly with orbital cellulitis. So if you find the movement is impaired, if you find vision is impaired, if you find pupillary reaction is impaired, this is orbital cellulitis, not preseptal. You should do CT scan. You should do imaging to rule out orbital cellulitis because most likely you will need here IV, not only oral. Most likely will need IV antibiotics. There is swelling of the lids, mild proptosis, واللي هو exophthalmos يعني, اللي هو protrusion of the eye. Pain is increased by pressure or on movement of the eyeball. Vision is not affected. However, it may be reduced in association with retrobulbar neuritis. Here we should be careful in number 4 because vision is mostly affected in orbital cellulitis. We're not talking about blindness, but the vision may be less, especially if the nerve is affected. As we mentioned, this is the eye, this is the optic nerve, and this is the cone. If we have inflammation that affecting an optic nerve, either directly or by the inflammatory process, by the edema is compressing the optic nerve, no, the vision will be affected. So this is not completely, أنا ماخذها completely من الbook. So if anybody will, يعني most of the lectures are from the books, but there are some يعني mistakes or not that accurate information from the book. So the vision is not affected, however it may be reduced and associated if associated with retrobulbar neuralgia. Okay, I can give this 50% correct. For me, vision is affected. Let's keep it general better. Fever and cerebral signs may be present due to central nervous system involvement. Fundus examination, it is difficult to examine the fundus. It may be normal, or signs of optic neuritis are seen with engorgement of veins, eventual optic atrophy sets in. This is how it looks at orbital cellulitis. Proptosis, marked swelling of lids and conjunctiva. فطبعا هنا you cannot see proptosis, you can see only swelling. Proptosis is protrusion of the eyelid. طبعا eyelid مغطى, you cannot see proptosis. يعني from here, if you see it like this, يعني from this photo, you never know if it's orbital cellulitis or precipitous cellulitis. You cannot know. How can you know if there is proptosis, if there is impaired in movement, if there is decreased vision, if there is affected papillary reaction? This is orbital cellulitis. In children in this age, if you see this photo or if you see this picture, image. حتى if it's precipitous, you never know. In children, يعني the examination will not be, the child will not be cooperative as in adults. So he may have mild orbital cellulitis. For imaging will show you, the image will show you if it's invading the orbit or only precipitous. This is how it looks. If you remember, precipitous cellulitis, first of all, let's see the A photo. This eye is okay. Let's check the level. هذا الpupil. See, the eye is downward displaced. So the right eye is proptotic, معناته is pushed anterior and downward. So mainly the problem is here, معناته, because the eye is pushed down and anterior. If you remember, with precipitous cellulitis, the problem was anterior to the septum here. يعني. Here we have it here as well. However, we have the orbit is filled with inflammation here. This, you can compare it to the other eye. The orbit here is fine. However, here we have inflammation in the orbit. This is caused the globe to be pushed anterior. Complications: abscess, pan ophthalmitis, and inflammation of the whole. Purulent meningitis can be transferred to meninges, will cause meningitis, cerebral abscess, optic atrophy. See, now يعني قاعدين ناخذ نفسه here. Optic atrophy results in permanent loss of vision, and there they wrote number 4, vision is not affected. So 4 is not number 4 is not accurate here in the book. Vision is affected in orbital cellulitis. So optic atrophy may result in permanent loss of vision to some degree, مو بلازم blindness لا. Both cavernous sinus can cause death. So orbital is very, very serious and is a top emergency in ophthalmology because you should treat it quickly. Investigations may include tetanus immunization, white cell count, blood of nasal discharge, high resolution CT of the orbit, sinuses and brain. Very important to image the orbit, image the sinus, image the brain. always يكون يعني دائما بيكون فيه انفرسيسيل. الساينس here is هذا الساينس مليانه. المفترض ان الساينس تكون كلير but هي عنده ساينسايتس. always الساينسايتس is the cause يعني most common cause of orbital cellulitis. A treatment admission, you should admit the patient. broad spectrum antibiotics هذه بتكون parenteral اللي هو IV يعني IV antibiotic. IV antibiotic. Analgesics and anti-inflammatory drugs are helpful in controlling pain and fever. Monitoring the optic nerve, this is very important. Number 5 is very important. Very important, number 5. Monitoring the optic nerve, because the eye is the important thing here. Monitoring the optic nerve function. What are the functions of the optic nerve? This is very important. What are the functions of the optic nerve? VA 1 اللي هو ال visual acuity. Color vision 2. Light brightness اللي هو ال contrast 3. Appreciation and pupillary action 4. Visual field 5. So we have five functions of the optic nerve. VA visual acuity, color vision, light brightness, pupillary reaction, and visual field. These are the 5 optic nerve functions, and you should monitor this in orbital cellulitis. If these improved, you know that you are in the right direction of treatment. Synapsis is formed, incision and drainage is done. كل 4 ساعات. نعم at least every 8 hours. لأن this inflammation infection is sometimes very bad. Within a day you may completely lost the vision. if you did not treat it quickly, and if you did not monitor it very well, you may lose the vision. So that's why you should monitor it at least 3 times daily, every 6 to 8 hours at least, because you may increase the dose of the antibiotic. You may do release. It depends, because you may do incision and drainage quickly. Done promptly, yes. Proptosis or exophthalmos is a condition where there is forward displacement of the eyeball beyond the orbital margin with the patient looking straight. Proptosis is synonymous with exophthalmos for practical purpose, but they cannot different meaning. And then unilateral or bilateral proptosis. The most common cause of unilateral and bilateral is thyroid. Thyroid eye disease is the most common for unilateral, and it's the most common for bilateral proptosis. عندنا inflammatory lesions like orbital cellulitis يعطينا غالبا unilateral, abscess unilateral. عندنا vascular disturbances like hemorrhage, varicose orbital veins, hemangiomas, هذه unilateral. Cysts and tumors like dermoid cyst, osteoma, lymphoma, lymphosarcoma, glioma, these are all unilateral. Systemic diseases like leukemias, endocrine disturbances such as Graves يعطينا unilateral اللي هو الثيرويد dysfunction. Paralysis of extraocular muscles, incomplete ophthalmology. Bilateral development anomalies of the skull, endocrine exophthalmos, endocrine اللي هي grapes نفسها thyrotoxic and thyrotropic. ايوثايرو يعني ممكن يكون ايو او هايبو او هايبر thyroidism. inflammatory lesions cavernous sinus thrombosis يعطينا bilateral tumors. Some of the tumors will give us bilateral. Intermittent. This is very important to differentiate between intermittent and pulsating proptosis. Intermittent, it means that the proptosis is not all the time there. يعني من التعريف you can know the cause. It's like the varicose vein. If you know what is varicose veins, you know that it's intermittent. Varicose veins اللي هي ان الveins will be distended with pressure. يعني varicose veins of the orbital varicose veins like in lying down or with holding your breath, the varicose veins will be engorged. And if the varicose veins engorged, you will have the proptosis. Otherwise, you will not have the proptosis. For intermittent, which means on and off. Intermittent means on and off, not all the time. So the cause is orbital varicose veins. However, in pulsating proptosis, pulsating معناته إن البروبتوزيس ينبض. There is a pulse with the proptosis, which means there will be a communication between the internal carotid artery and the cavernous sinus, which is the arteriovenous aneurysm or CC fistula. We call this CC fistula. C, the first C is the carotid, the second C is the cavernous, wa fistula. Fistula, which means there is communication between the carotid and the cavernous. This will cause proptosis, but it's pulsating proptosis because of the carotid artery. Clinical evaluation, history, mode of onset, whether sudden, gradual, chronic, presence and duration of pain is important. Past history, dysfunction is very important. Most common cause, orbital trauma, sinus disease, malignancy, clinical examination. It's important to rule out the possibility of pseudoproptosis. Pseudoproptosis, which is not a proptosis. Pseudoproptosis means that we can have buff thalamus as in what? As in glaucoma. Understand, congenital glaucoma, the eye is large, but it's not anteriorly displaced. The eye is in place, but it is large. It looks like it is proptotic, but it's not proptotic. It's only large. This is buff thalamus. High axial myopia is the same. High axial myopia, we said high axial معناته عندي axial length of the eye يعني large eye. Retraction of the eyelid. The eyelid will be retracted up. However, the globe is not anteriorly pushed. Only the lid is up, retracted up, and you will feel that the eye is pushed anteriorly. However, it's not. Only the lid is retracted. Shallow orbit. The orbit is small, and you will feel that the globe is proptotic. Clinical evaluation or measurement of proptosis by clinical observation. The patient may sit in front of the surgeon. His head is tilted slightly backward, and the position of the apex of each cornea is compared on both sides. يعني يرفع راسه ويشوف للأعلى, and you will check by vision. يعني you will check if one eye is anterior to the other. The second method, which is more accurate, اللي هو exophthalmometer. There is limitation of ocular movement due to edema, emphysematous fibrosis. Visual acuity may be reduced as a result of exposure. Keratitis, very important. This is very important. And visual acuity may be reduced as a result of exposure, keratitis, and optic nerve involvement. Because, as we mentioned, edema may cause pressure على الoptic nerve, فالvision will be affected. Again, pupillary reaction, يعني الoptic nerve function اللي ذكرناها كلها بتقل. الفيلد, الفيجوال acuity, الpupillary reaction, اللايت, light contrast, all of these will be affected. Fundus examination, disc may be normal or shows features of optic atrophy or papilledema. Transillumination and auscultation are done for tumor and pulsating proptosis. It's very important to do imaging, especially CT or MRI. Labs is very important, خاصة الثيرويد and other causes. Orbital venography is very important for the varicose veins. A treatment exploratory operation and biopsy are done إذا كان عندي suspected tumor. Surgical excision if the case of benign tumor, dermoid cyst. Exentration is the removal of everything. Radiation in case of recurrence and bits. Thyroid eye disease is very important topic. Exophthalmos and thyroid is an active process. The exact cause is obscure as it may be present in hyper, hypo, and euthyroid state. It may be associated with generalized disturbance of the endocrine system, increased secretion of thyrotropic hormone or thyroid stimulating hormone TSH from the anterior lobe of pituitary gland in response to low thyrotoxin level. Increased secretion of exophthalmos producing substance and long-acting thyroid stimulators. Pathogenesis, there is delayed hypersensitivity or autoimmune reaction to thyroglobulin leading to edema, infiltration, deposition of fat and mucopolysaccharide substances and fibrosis of the orbital tissue. Very important in pathogenesis. In hyperthyroidism, thyrotoxicosis اللي هو Graves disease, عندنا exophthalmic goiter. In hypothyroidism we have the exophthalmic ophthalmoplegia. There is anterior protrusion of the eyeballs with inability to close the eyelids. As signs, very important the signs هذه Van Grief, Mobius, Geoffroy's. Features of thyrotoxicosis include tachycardia, اللي هي الجنرال features. Tachycardia, fine muscle tremor, هذه you should know this بالمedicine. Ocular signs, bilateral exophthalmos with associated exposure keratitis. Dalrymple's sign, there is peculiar stare due to the retraction of the upper lid. It's the most common sign. This is the most common sign اللي هو lid retraction. Dalrymple's sign اللي هو upper lid retraction is the most common sign. Von Grief's sign اللي هو lid lag. The upper lid lags on downward movement of the eyeball. Von Grief's sign اللي هو lid lag. Dalrymple's sign اللي هو upper lid retraction. So Von Grief lid lag. When the patient looks up, then a globe downward movement, the globe will move, however the eyelid will not move. This is Von Grief's sign. Stillwags sign, there is infrequent and incomplete blinking. Mobius, there is weakness of convergence. Mobius signs, okay. Then we have the Jelinek and Geoffroy's sign, which are increased pigmentation and poor forehead wrinkling on looking up. This is the exophthalmos and thyroid disease. This is proptosis. This is the lid retraction. As we mentioned, thyroid eye disease may be unilateral or it can be bilateral. So unilateral here, bilateral here. So the lid is retracted The lid here is retracted. How can you know this? You can see the scleral show. You can see the scleral. The eyelid should cover part of the cornea. يعني الeyelid المفروض انها تنتهي تغطي جزء من الكورنيا. However, here the whole cornea is shown and part of the sclera is shown as well. Here part of the sclera, this we call this scleral show. معناته عندي lid retraction. So I can know that the lid is so retracted compared to the other normal eye. Here both eyes showing scleral show. This is the lid lag. عند المشكلة هنا في right eye. So when the patient looks down, the lid will not go completely down. This is the lid lag, Mongreaves sign, Darlimp's sign, lid retraction. Thyroid eye disease is very important, خاصة الفوتو هنا. Blood tests. We should do thyroid function, TFT, thyroid function test. طبعا ضروري. Optic nerve evaluation is very important اللي هي الفانكشنز اللي ذكرناها الفايف. Field, visual field, visual acuity, pupillary action, الكونتراست, اللايت، هذه كلها you should do them. MRI CT اللي هو خاصة imaging يعني of the it's very important. There is something specific or pathognomonic for thyroid eye disease, and it is tendon sparing. Here you can see the muscle really is enlarged. However, the tendon here is not. The tendon is spared. The tendon is not enlarged. اللي هو الending يعني الending is not enlarged. This is specific for muscle involvement in thyroid eye disease, because in myositis يعني in inflammation of muscles other than thyroid eye disease, the whole muscle will be enlarged, even the tendon. However, here the tendon is spared. The tendon is not enlarged. So treatment systemic iodide and antithyroid drugs are given in mild type. Systemic steroids help to reduce edema and infiltration. Exposed cornea is protected by lubricants, taping, and lateral tarsorrhaphy. Orbital decompression is indicated in rapidly progressing proptosis and optic nerve involved. It's very important to do compression. If the optic nerve is involved, it means that there is something pressing the optic nerve, and you need to decompress this pressure by orbital decompression. In ophthalmos is the opposite. It is a rare condition in which the eyeball is displaced inward, not outward, it's inward. Etiology, structural abnormality. It is seen in blowout fractures. Very important that the blowout fracture will cause in ophthalmos, phthisis bulbi, microphthalmos, and other congenital defects. And then atrophy of the orbital content. It is seen in orbital varicose veins in old age and after radiation for malignant tumor, خاصة metastatic breast cancer. We have traction. It occurs due to inflammatory cicatrization, extraocular muscles as the pseudotumor syndrome and after excessive shortening of extraocular muscles. So this is in ophthalmos here, and we'll talk about this in trauma lecture. So this is in ophthalmos. If the patient has blowout fracture, the floor will be fractured and the globe will go just down and in. So this is in ophthalmos. This is the normal eye. This is in ophthalmos. The eye is inwardly displaced. That's it. any question طلال حربي تفضل.
السلام عليكم دكتور. دكتور
وعليكم
بالنسبة
السلام.
للسي تي سكان هل هي بتكون معنا في الأوس بي؟
الأسئلة دي أنا ما بحبها ترى.
لا والله هي مهي بمسألة دي، بس قصدي عشان
الليكتشر you can be asked about.
احنا ما أخذنا السي تي نفسها أساسا.
ما هي مشكلة، أخذتها اليوم.